Okay, we
All
are
right.
being recorded.
All right, thanks. And if you could just scroll the agenda up just a little bit to the agenda details, that'd be great. Excuse me. Good afternoon, everybody. I'm Lisa Emerson. I'm a Senior Policy Advisor with the Division of Financial Regulation. Thank you for being here today. Today is the fourth Rules Advisory Committee meeting for House Bill 2002, Gender-Affirming Treatment Rulemaking. I just want to let you know that Brooke Hall, my fellow senior policy advisor who's been helping lead this RAC, she won't be able to be here today for personal reasons, and she does send her regrets. She will, she's worked very closely with me on all the materials that we're going to discuss today, and I'll be sure to update her. And want to also let you know kind of right out of the gate that we will have another RAC in May, another Rules Advisory Committee meeting in May. And we're tentatively looking at May 23rd as a target because the following May 30th is, during the week of a holiday. So a lot of folks may not be available. So I just want to give you a heads up about that. That's what we're planning and what's going on with Brooke. So as far as housekeeping goes, and welcome everyone. I just want to, as a reminder, let you know that I did put a link to the RAC page on our website in the chat. So if you, for some reason, can't find your materials or, want to reference those materials, are all posted on the web page. In addition, the list of RAC members, official RAC members, is on that page. And so as a reminder, the main bulk of the meeting is going to be a discussion between RAC members and DFR staff. There will be an opportunity for public comment from interested parties at some point in the agenda on agenda item number 4. We will take some time to invite those that submitted written comments to just hit the highlights of their comments or whatever they'd like to share about them. And we did receive 8 written comments, so that'll take some time to kind of walk through. And then we'll review the revised draft rules, starting with what is now subsection 7, which is the network adequacy piece. So we did some renumbering because of the revision. So we'll be starting with subparagraph 7, and then we'll go back to the other parts of the rule that we've made some revisions to. As far as just, etiquette for virtual meetings, if you could please, stay muted if you're not speaking. You're welcome to be on camera when you're speaking or not. Of course, staying off camera while you're not speaking might help with the bandwidth with Teams. And then when you do speak, if you could introduce yourself and who your organization that you're affiliated with or your role with the RAC, that'd be appreciated. And please use the raised hand function so that we can keep our discussion organized. And yeah, I don't think I need to remind, but I will. But this is just a forum that is a respectful place. So let's just be keep our comments very respectful to others that are participating here today. So what else? Yeah, and also when the comment submitters are discussing their written comments, just keep in mind that we haven't spent a lot of time on the network adequacy piece. We're focused really more on other sections for the revisions, and of course, we'll be continuing to deliberate over all the information on all parts of the rule. But we're still vetting all the ideas about network adequacy still. All right, with that, let's begin. I'd like to invite, again, comment submitters to have an opportunity to just hit the highlights of their written comments, anything they'd like to share, and we'll go in alphabetical order by organization. And I'd like to start with Seth Johnstone with Basic Rights Oregon.
Thanks so much. So to speak to the written comment that Basic Rights Oregon submitted, looking at Section 1B to begin with, we were concerned about the addition of the revised language referencing other evidence-based guidelines, and based on the discussion that we had, the Fenway Health edition was mentioned, and we just wanted to clarify that those rules were also cited in WPATH 8, and so our encouragement was really to focus on not other evidence-based guidelines that have not had a chance to be reviewed, but the WPATH 8 as the official standard of care that we would be considering in this instance for this RAC, and that one RAC could always be reconvened if additional evidence-based guidelines are published, but there weren't others that we found that were mentioned in the previous conversation that would be useful in this that in conjunction with. And then accepted in its entirety was really our real big focus for WPATH 8. I think there's been concerned about one specific appendix, but not that the statements of recommendation be the only components that are acknowledged. And I think we can have a further conversation today about navigating that appendix, but that the statements of recommendation do not include enough. The really bulk of WPATH 8 is what follows those statement bolded sentences. Um, Additionally, looking at 5B2, considering the practicing within the scope of their license, we discussed that at our last DFR RAC meeting here, that we were looking just for more detail within that sentence, of which was added around, practicing within the same field of scope. For Section 5 IV, we were looking at more specificity on the required training. There's been some questions about the frequency of online courses offered. I think that could be researched and created. We've researched a lot of equivalent courses available online, and there are not a lot of equivalent courses for WPATH, but that seems critical for reviewing and being familiar with WPATH 8 in contrast to 7 when making these considerations and being able to decide if it's in line with the standard of care that's currently published. So I think some conversation could be had around that frequency and research, but we do find that that is the one course that really is available for folks online. Recommended also a section be considered within Section 5. We saw folks asking where that came from. That was Washington rulemaking for Senate Bill 5313. The Washington rulemaking was actually more specific on behalf of consumers so that they can have more information about which specific guideline, rule, policy was creating the denial, and some information about the reviewer themselves, not personal information, but their credentials in the gender-affirming care arena. And that was our main comment. And then we cited that recommendation in rulemaking from Senate Bill 5313.
Thank you very much, Seth. Now let's go to Antoinette with Cambia.
Hi, good afternoon. Again, this is Antoinette from Cambia Health Solutions. Thanks for giving us the opportunity to provide or summarize the written comments that we provided. And I'll keep this very brief as you have it up. We just focused on 3 areas of the revised draft rules. One was the definition of accepted standards of care. The second was the section addressing denial of claims, and of course, network adequacy. And I appreciate you mentioning ahead that the DFR hasn't really delved much into that piece of it. So it's good that we have some time to continue discussions on that. But regarding the definitions of accepted standards of care, we did emphasize the importance of keeping the statements of recommendation, particularly because, there are procedures that are included in other sections of WPATH guidelines that are considered experimental or not widely agreed by medical professionals to be safe. So again, these and also as seen in the appendix, or just statements of recommendations, and that's it. With respect to denial of claims, there were some additional provisions added regarding the qualifications of the physical and behavioral health care provider. And in the last RAC, it was mentioned that that language was came out of Washington's. We did a thorough review of the Washington law, and also what the Washington OIC prepares with when they're doing rulemaking is something called a concise explanatory statement, and we also attached that in our submission. That did not actually address or provide that definition at all. So we were wondering exactly where within the Washington law and rules that came from. And lastly, regarding network adequacy, we asked for, among other things, for the definition of unreasonable delay to be specified, as well as other asks, again, relating to network adequacy. So it's all in there, but I am happy to hear that we do have time to flesh some of those out. So that was it. Thank you.
Thank you, Antoinette. And next, let's please go to Jonathan with Cascade AIDS Project.
Hi, can you hear me?
Yes.
Okay,
Yes,
sorry.
we can. No problem.
Jonathan Peroxide, him pronouns, Public Policy Manager for Cascade AIDS Project. And my comments just focused on network adequacy, the network adequacy section. So given that we haven't quite gotten there yet, I'm not sure it's valuable for me to give a detailed, I'll share more about those comments when we have a substantive conversation about that section, if that's all right.
That's just fine. Thank you, Jonathan.
Okay. Yeah, thank you.
Next, let's go to Marlene Converse with Kaiser Permanente.
Hi, good afternoon. We had a few main comments that we included in our letter. So on the accepted standards of care, we were clarifying that it wasn't just the bolded sentence that we plan to cover, but that it is helpful to include some sort of language in the rule that is talking about statements of recommendation, so that some of how we navigate the appendices and what might not be a typical service that would be covered. It's going to be important to have the regulation continue to clarify the language about that. We made a comment about aligning with statutory language, so including the word procedures, because the word of procedures is in the underlying statute, just so that we don't gradually wander away from what the statute is saying. On the training, we agree that the gold standard is the WPATH Global Education Institute Foundations course. However, it's not offered very often. And from a practical perspective, we are concerned that we don't want a regulation to get adopted that doesn't allow a little bit of flexibility for other equivalent courses to be taken by providers, because if a course isn't offered until September and the DFR adopts a regulation, in early spring, then it leaves this period of time where somebody may need to go get training, but there isn't a course available. And so we need to figure out how to navigate, if we're requiring a specific course, how we can get people signed up to take those courses. Thank you very much.
Thank you, Marlene. Next, let's go to Chris with Oregon Consumer Justice.
Thank you. Yeah, and I will be brief. Also, really just in the written comments, we reiterated some of what we shared, or I shared at the last RAC, first about in section 1B around not relying just on the statements of recommendation, but really the whole WPATH 8, and also the question about other evidence-based guidelines and recommendations, and just the good robust conversation that we had at the last RAC. And just again, we can reopen rulemaking if there are other guidelines that are put forward, but it didn't seem as though anyone was able to bring anything forward. And then we also talked about the training and looking to the Global Education Institute, and finally around the denials looking at SB 5313 from Washington and going into more detail there about just making sure that consumers really have an understanding of what their rights are when there's a denial and how that's being handled. So thank you.
Thank you, Chris. And now let's go to Tara Harrison with Providence Health Plan. If she's
Hello,
able to
my name
please.
is Bo Wrights. I am a policy analyst with Providence Health Plan. I'll be participating on Tara's behalf today.
Okay.
So our letter is specifically pertaining to provider contracting and network adequacy. So our letter, we initially addressed the language in the previous iteration of the proposed rules, where the DFR would exempt carriers from proposed network adequacy standards in circumstances where carriers could not meet those standards due to exclusively provider scarcity. And we requested that the language change to include exemptions in any unforeseen circumstance such where the carrier can demonstrate good faith contracting efforts with gender-affirming treatment providers. The next portion of the bill, we do understand how it may be out of the scope of rulemaking. However, we do want to share the concerns. So the issue with the rule, which I believe is taken from statute, is that it requires carriers to pay potential providers out of network in the case they cannot meet network adequacy standards. And we believe this may potentially de-incentivize providers from contracting with carriers. And we do have a fear of potential inflated prices. So we would kindly request that the DFR explore other mechanisms to prevent such an issue.
Okay, thank you, Bo. And let's see. Do we have anyone representing Pacific Source with us today? Is Rick Blackwell on? I don't believe so. Again, you know, his comments were shared via email, and they're also posted to the RAC website. So let's skip ahead and we'll go to Rachel Arnold with Samaritan.
Good afternoon, Rachel Arnold with Samaritan Health Services. I am not going to go over much of this because it's already really been stated. We had some comments around the inclusion of the utilization review language, which we were in support of. We also had some comments around the training requirements. And I think the one thing I'll mention there that I don't think has been mentioned previously is we were also just asking for some consideration in terms of the balance between the requirements and the training or types of training and the already small pool of providers that provide this type of service, and not making it too onerous so that we don't have providers that are even willing to go through the training. So that was what we included there. And then the last point was just in terms of the providing some clarity around what unreasonable delay means. And that's it.
Thank you, Rachel.
Of course.
All right. I think unless anyone from the RAC or DFR has any immediate question, might just continue with, you know, going into the actual review of the draft rule now, and then we can, you know, pick up on comments in the respective parts of the rule. So we want to go ahead and bring that up, Karen, that'd be great. And starting with 7, sub 7 on the second page, we'll start with the network adequacy discussion to make sure that we fully discuss this section here. All right. So I think the main comment that we're receiving is the question around what does unreasonable delay mean? And also the issue around, you know, timeframes, like, some of the different network adequacy standards that are going to be actually put forth and be effective for, say, qualified health plans in the 2026 plan year, do involve wait times standards. So that is kind of something I wanted to kind of put out there, that, if you aren't already looking at that information, you're probably, and I would assume the insurers are probably aware of that those standards will become effective in the 2026 plan year. So that is something to think about. There's different standards for wait times for non-emergent specialty care, non-emergent primary care, and also for behavioral health services, and then of course there's standards for emergency services for both medical, surgical, or behavioral health. So that's a frame of reference or something to consider. Let's see. So really, I think what we're looking for, which would assist the division, is to have suggestions from insurers and also from advocates on what would be unreasonable delay. So I don't really have anything to put forth, directly, other than to suggest some materials to look at. I think we already did mention that the division is at some point in the future going to be engaging in actual in network adequacy rulemaking, probably for the broader scope of network adequacy. So just kind of putting that out there as a starter for this conversation. So I welcome feedback in the order of people raising their hands. And so I'll start with, I believe it's Scott White.
Hi, good afternoon. Scott White, Director of Regulatory Affairs for Moda Health. I was just wanted to go back to the wait time standards provision that you mentioned. So that would be effective 1/1/25, but only for FFEs, not state-based exchanges using the federal platform. Is there a different wait time standard that you're referring to for that's Oregon specific? Just want to clarify.
No, we don't have anything specific in the Oregon law or rules at this time that mirrors what CMS has put out for qualified health plans. But we have to, and I have to go to my reference here, but there will be coming up in 2026, state-based exchanges and state-based exchanges that use the federal platform must establish and impose quantitative time and distance network adequacy standards for QHPs that are at least as stringent as the standards put forth by the federal government. So that's what I was referring to.
Oh, okay. I just didn't want wait time standards to be confused or added in here thinking they would apply to Oregon when they wouldn't. Okay, thank you, Lisa. I appreciate it.
Yeah, and so just to kind of tag on to that, your helpful question there, Scott, is that we would welcome feedback from those of you who are familiar with those regulations forthcoming, and how that might, be applied to the gender affirming treatment in terms of those requirements. Let's see, our hands up. Antoinette.
So quick question then. When does the DFR think they'll be engaging in those rulemaking for network adequacy then? Since the wait times really do not apply to Oregon, because come 2026, we're not going to be on the federal exchange anymore. It's going to be more of a state-based exchange.
My understanding from reading the materials is it applies to both state-based exchanges and state-based exchanges using the federal platform beginning with plan year 1/1/26.
Okay.
And I can forward that some material that I just became aware of for your reference.
Okay.
So that's
that'd be great.
something that we're talking about, but I actually don't have a time frame for when we might engage in rulemaking for network adequacy. So that kind of needs to be considered, while we're engaged in the topic of unreasonable delay as it pertains to gender affirming treatment. So we're looking to the RAC members for ideas with respect to what would be a good definition for unreasonable delay, what kind of time frame for different kinds of treatment, and maybe those federal standards would be something to look at.
Okay. Great.
Yeah. For example, I think one that I was reading was for non-emergency specialty care. The time frame was, I believe it was 60 days. So there's a lot of detail, and I can forward that out to the group for consideration because it's public information. It's out there. So any other questions around this network adequacy piece, other than we will continue to review comments that have already been made, verbal and written, and also I will ask for additional written comments after this RAC to probably be received within 2 weeks to queue us up for our next RAC in May. And also welcome feedback with some of the other suggestions or concerns around out of network, when out of network would come into play. And again, that comes down to the unreasonable delay definition. So I see, Jonathan, you have your hands up. Please go ahead.
I guess I'll just take this opportunity to flag that in the public comment that Cascading's project submitted about the network adequacy provisions, we didn't propose a definition of unreasonable delay, but we did propose requiring review by DCBS to at least provide, to not leave this entirely into the judgment of individual carriers, and that we just took language that already exists in OAR, the OAR related to annual report requirements for network adequacy. So that's what we've suggested in this area. Thank you.
Thank you, Jonathan.
I have a question. Can Jonathan expand on that a little bit in terms of the reporting? I'm not seeing the connection. I'm sorry.
Sure, I will offer that opportunity to him, and then I can do my best to kind of provide additional explanation if I can. So go ahead, Jonathan.
I'm not sure I understand the invitation to.
Yeah, I think I understand.
More. Oh, okay, go ahead.
Yeah. So I think Antoinette's wondering how our current rule for network adequacy, as far as annual reporting requirements for carriers, reporting on the network adequacy fits with this section of the rule. And, you know, is that enough? Maybe not enough definition around the issue around unreasonable delay. So that I think that's what you're saying, Antoinette.
Yeah, because I mean, we will see this annual reporting that insurers are required to do. You know, we should continue doing it the same regardless of the service. That gender affirming care should not, gender affirming treatment should not be treated differently. So that's where I'm coming from. So I don't know whether you're trying to change the network adequacy just for gender affirming treatment.
Yeah, I can respond to. Oh, sorry.
Okay. Yeah, I don't want to suppose anything. So please go ahead, Jonathan.
Well, I guess I disagree with that statement that we can treat gender affirming treatment like we treat what carriers are reporting in their annual network adequacy reports, because gender affirming treatment spans all these different specialties. So if
right now, insurers are reporting about, say, primary care access. That doesn't necessarily say anything either way about what they're doing specifically related to gender-affirming care. So, I mean, you can review the comment. Obviously, it's public, but all I really did in my proposed language was take language from statute and reframe it as questions that insurers would be providing a narrative to DCBS about. Again, I'm not attempting to answer the question about the definition of unreasonable delay or anything, just suggesting that that yes, there be a specific narrative required as part of annual network adequacy reporting that addresses what the statute requires in terms of their process for contracting with a network of gender-affirming treatment providers. It's sufficient. It would specifically require that information.
Okay, and I'm not going to go back and forth towards with the law and the rule here, but I would probably have to pull up the law again and refresh my memory in terms of any additional reporting just on gender-affirming treatment, because we need to be careful here in that we need to basically, I guess, follow what is authorized under the statute versus what we're any additional reporting requirement we're trying to bring in into this. That's the only place that I'm coming from, just to make sure that we're not adding onerous reporting requirements that are outside of what's authorized by the statute. Sure. Thank you.
Thanks, Antoinette. Yeah, I think just revisiting the law and the rule will hopefully make more sense about what Jonathan is trying to apply. It's just that carriers be reporting on what they normally would be required to report on with respect to medical, surgical, and behavioral health services. So just, yeah, perhaps revisit that, and we welcome additional feedback. And again, I will share, some of that material that I've mentioned about the federal standards that are forthcoming that do get down very specific into primary care, behavioral health care, specialty care by provider type. And so that's out there, and I'll just want to make sure and get it in front of you so you all have it to look at as something to be thinking about. Okay. Any other questions or comments from RAC members, or I even invite DFR staff that might be on the meeting today. So let me go in order here. I see some hands. Let's start with Scott White.
Hi, good afternoon. Scott White with Moda Health. I just wanted to clarify something, and I saw this in one of the carrier letters as well, just regarding out-of-network services and not without additional cost sharing being incurred by the member. And I just want to clarify, or I wonder, Lisa, if the DFR wants to clarify, because historically cost sharing has not meant any balance billing. This is co-payments, deductibles, et cetera, as the definition of cost sharing there. And I know there was a concern about that in one of the carrier letters, talking about payment caps or no incentive for a provider to contract with us if, we're going to pay everything at an in-network rate anyway. But what's important to understand would be that would not include, or to verify, I should say, that would not include balance billing that could come to a member, which kind of reiterates the importance of some of the other comments from carriers that members work with us first to try to find in-network, or that we can work out a single case agreement, because if they just go to California, for example, or something like that, which is, again, the common example used, just because I think there are more providers available, that balance billing would still be in effect for that. I do not read this, when you say cost sharing, to mean, that balance billing would be excluded. So that would be important as a member to understand as well, going to these services. And again, just reiterating the fact that it's important that there's provisions in here, and I know you haven't got to this piece yet, that they work with an issuer to try to find this before going out of network, because there are additional concerns other than just, the in-network cost sharing.
Yeah, thank you, Scott. I believe I know the answer to the question you're asking is that the cost sharing is more about deductibles, co-pays, co-insurance. We have a balanced billing law, and there's also the No Surprises Act, the federal No Surprises Act. So we have to kind of take all that into consideration for all related medical, surgical, or behavioral health services. So I'll say that much right now, but we'll definitely take a closer look at that issue. And one thing that would really be helpful is to hear from insurers some specifics about your current policies. I've done a little bit of reviewing of policy forms, and yeah, what you mentioned, Scott, is that there are in the plan documents, you know, as is required to provide written information to enrollees, you outline what are the steps for that enrollees can take to find care, whether in network or out of network, and have to get, in essence, prior authorization for perhaps a single case agreement when reasonable, and also so that's in the your plan documents, and that's certainly not prohibited. But then we get back to the question about when. What is a reasonable time period? We don't want to have a unreasonable delay for access to care. So I think we're trying to get better definitions around that. And I think that's where some of those federal standards forthcoming could be really helpful talking points around this issue. And I would like to hear, how do you, as carriers, typically, what are your standards for when you would agree to a single case agreement? Kind of what are reasonable standards would be helpful to hear from the insurers on that piece, how you currently handle things. So I thought I saw somebody's hand up, but I think I'll go a bit to Antoinette.
Yeah, and I was just going to follow what Scott said from MODA. We agree with him 100%. Obviously the law kind of lays out not so much the framework. It states what we're required to do, and this rulemaking is intended to put some of the meat on the bones, so that we're all on the same page, consumers, advocates, insurers, with respect to how we operationalize this and implement this. So, to also add to what Scott said, we would also, it's really important also that the member, reaches out to us with respect to wanting to receive services, out of network. I'm just kind of emphasizing what you just said, because, it shouldn't be the carrier's, burden or put on the carrier to know when a member is wanting to do this and to expect the member to reach out. So I think it's important to actually put something in the rulemaking that requires the enrollee to contact their carrier for assistance in trying to find an out-of-network provider, and also if a provider in network cannot be found, the steps we can take to make sure that the enrollee gets the services that they need. So we think it's really important to include that. Also in our comment letter, we also requested that really it should be trying to help the enrollee find a provider in state to facilitate their access to gender-affirming treatment. And I think that's really also important to include. We do have language that we would like to offer the DFR, and we will do so in our comment letter. So I was just, speaking to emphasize some of the points that Scott made and some of the points that you made as well.
Okay, thank you, Antoinette. And I think you'll find that when we look at some of the other information under that relate to the adverse benefit determinations, the law that we put in there, as well as the rules, I think that will maybe hopefully make it clear to everybody involved about that there are very clear requirements about written communications to enrollees that carriers need to make. And our rules and laws pertain to insurance companies and not enrollees. So we really need to be specific to the laws and the rules that pertain to the carriers. And then you would communicate that as you do through your written materials, what the steps are for seeking care. You've got your prior authorization rules, timeframes, that sort of thing. So we'll get back to that in a moment. But let me go to Seth. Have your hand up.
Yeah, it looks like Jesse mentioned it in the chat, but I just had a question about regulating behavior of patients or enrollees and whether that happens here in rule or shouldn't happen here in rule. My other question actually was around, I wanted to cite that I'd found actually research on the GEI courses, and just was wondering where in the agenda to present, but if folks, it doesn't look like there's any other hands up, so I can present that now if that's helpful.
I actually,
But if you want to stay here, we can,
I will
yeah.
partner with you on that, Seth, because I did a little research too on that topic. And I before we maybe move on to that, let me make sure that we are kind of done. We're going to table this section of the rules discussion. Any other comments or questions around subsection 7? Okay, I see. Bo, you have your hand up. Please go ahead.
I apologize. This is more related to subsection 8. However, I just want to reaffirm in Providence's comment letter the due diligence, regardless of provider scarcity, given there's still a demonstration of due diligence in contracting with providers.
Thank you for saying that. I actually was meaning to address 7 or 8, A and B, because they're kind of all wrapped into a similar area. So thanks for reminding me about that and stating that. Okay. Karen, let's go ahead and let's not go too backward. Let's start at the very beginning. Go to the first section of the rule now. And so here we've presented our revised language after considering the verbal comments, written comments, and discussion, and additional research. As has been mentioned, the WPATH 8 is the standard of care that's been developed over many years, with the most comprehensive version coming out in 2022 with the version 8. And we did look at some of the other suggested potential standards of care, which, as I believe Seth mentioned, the WPATH 8 does have references. They cite multiple references, and that did include a reference to the Fenway Medical, which is they're a federally qualified health center. They have a document, the Fenway Medical's Care of Trans and Gender Diverse Adults, dated spring 2021. On page 5, they reference that they use the WPATH 8 as a standard of care as far as the protocols they've designed. So they are, they regard the WPATH 8 as a standard of care, and also, that is for medical and behavioral health care for transgender and gender diverse persons. So that appears to be the universal standard of care, and we feel that it's important to use all the document in its entirety as well. So that's why we made that revision. And again, if as this space is ever changing, and if we need to consider other standards of care, we could revisit this through re-engaging the RAC and having a future discussion. And also the WPATH 8 is the standard of care for the Oregon Health Plan as well for CCOs. And it's also the standard that has been put forth by the Oregon Health Authority's Health Evidence Review Commission. So that is where we're at, but we welcome comments from anyone that would like to make comment or have questions. Okay. Hearing none, let's move to sub 2. Here we were trying to clarify that what we've put in rule from statute, what we're trying to do is further inform the statute by providing examples of what it means for a health benefit plan to not deny or limit coverage under the plan. So it would be including, but of course not limited to, these are examples. So this is to further inform the meaning of the statute. And that we thought would be a reasonable thing to do. And we will have an opportunity for public comment. I just saw your chat, Paul, and we'll have an opportunity for public comment in a little bit once we get through the roll. I see that, Rick, let's see, Rick, you have your hand raised. Please go ahead.
Thanks, Lisa. Rick Blackwell, Pacific Source. Sorry, I was late getting here. Just wanted to reaffirm statements I made in my first comment letter in my email regarding the characterization of how cost share works in the proposed section 2 of the rule. I think cost share under the statute was really limited to making sure cost sharing was no more restrictive in out-of-network providers than for in-network providers. And so I don't think this really I don't think this really jives with the way the statute is written. So I'm raising that again. Thanks.
Okay, thank you. We will take that under consideration and look at that again. And then 3 was added, subparagraph 3 was added to provide more information and clarity that carriers may still use utilization review practices, but they still need to adhere to subsection 2, B, 2A and B. So it's just to kind of provide clarity around utilization review practices. Anybody have any questions or comments about this addition? Okay. Hearing none, we'll keep moving on. So we did some renumbering because we added a new paragraph, so that changed the numbering. We did, take comments under consideration. We added procedures to, I think it's here, it's 5 under 4B and to align with the statute. And then we did some revising of subparagraph 5, section 5, just to kind of do some rewording and add more detail. So the first paragraph here is just kind of says the same thing, but is reworded because we're listing some additional information that plans must ensure that the adverse benefit determination is reviewed and approved in accordance with the following requirements, starting with little A. The adverse benefit determination is reviewed by a physical behavioral health care provider with experience prescribing or delivering gender-affirming treatment. And the reviewing provider must, meets the criteria for external review that's found in OAR 836-053, 1325, 6B, A through C. And that I can actually share my screen and show you that language if you haven't already referred to it. That might be helpful. Just a moment.
So Lisa, do I do a stop share?
Probably. I hope.
Okay, so I'm
trying to find that. Just trying to find the document here.
I understand.
Can you see my screen?
No,
Karen?
No.
no,
Okay.
no, not yet.
All right. Hold on. Can you see it now?
Something's coming up, but
Okay.
there it is. There it is.
Okay. So what I was trying to, so you could see it better and not have to go and search in the rules for it. This is the reference that we're making in the revised draft rule. These would be the standards that the reviewing provider would need to meet, which is similar to the requirements for the external review process. So that is external review is the processes after that an enrollee can ask for, that is after the internal appeals process, which the internal appeals process, a carrier and enrollee can move to the external review. You know, they can choose to end their internal review process and move to external review quickly. There's a whole bunch of rules around this. So we felt this is already in our rules and it's descriptive and similar to what some of the comments have been from commenters about wanting more detail about the credentials of the reviewing provider. So they need to have expertise to address the issues that are at the source of the dispute. Be a clinical peer for purposes of this paragraph. A peer is a physician or a medical provider who's in the same or similar specialty that typically manages the medical condition, procedures, or treatment under review. Generally, as a peer in a similar specialty, the individual must be in the same profession and same licensure category as the attending provider. In a profession that has organized board certified specialties, a clinical peer generally will be in the same formal specialty and have the ability to evaluate alternatives to the proposed treatment. So I just wanted to share that information for you and see if you have any thoughts on that. And certainly you can take that information back, you know, take time to look at that on your own and then provide any follow-up comments. That we were just trying to get more detail there for the purpose of this rule. Go ahead and put the rule back up, Karen. And then next we're getting to the part that I know Seth wanted to make a comment about. Another part of the criteria is that the reviewing provider has completed the WPATH Global Education Institutes. That was a typo there. I think they use initiative in other parts of their material, but it's the Institute's Foundations in Transgender Health, which is with our further research, we understand that the foundations is a very good starting place for that in that training suite of training that is available through the WPATH Global Education Institute. And so Seth, if you want to share the information that you had about that, I'll let you go first and then I can fill in the blanks.
Sure. Yeah, I know there were some questions and comment about how often these were offered and the timing. The courses are offered 4 times a year if we're looking at the foundations course, and some of them are virtual, so accessible through that route. And there are also, there's a US conference that takes place that is hybrid as well, that's called US Path, where foundations is also offered. So I just wanted to cite that there is also a schedule on their website that our staff are able to elevate and colleagues in the Oregon Trans Health Coalition. And I've put that here in the chat.
Thank you. Yeah, and we also added on there that that is a kind of an accredited, recognized training program, or we may find that there are equivalent or as well accredited training programs that we could vet and then list on our website. So we added that additional language. Even though we're having a hard time finding what those are, it kind of leaves room for considering alternative training that would meet the expectations. Rick, you have your hand up. Please go ahead.
Oh, yeah, thank you. So 2 questions. I guess if someone was a clinical peer, would they be taking this training program to stay within that specialty anyway? And then two, I am curious how much this would cost. I feel like that would have to be worked into the fiscal impact statement just to understand how much this will be.
Thank you, Rick. We'll talk about your first question and then your second question about the cost. Yes, for this, there is a cost. There is a membership for clinicians. Usually they pay an annual fee to then access these trainings. And I'll work with Seth and Amy Penkin with WHSU to kind of pull together maybe a little kit of information on this topic of the training and send it out to the RAC. So you have that information. I was able to download a few different pages, so I'll work with them on pulling that together. Okay, any other questions? I haven't really been looking at the chat, so of course available for non-emergency. So there's some information in the chat about this, and then we'll do some additional follow-up with some PDFs of information as well. Let's go ahead and move on here. We just again did some renumbering due to editing that section 5. And then now we're back to where we started. So any other questions, comments from RAC members or anything that any of the DFR staff that might want to share or add? Now would be a good time before we move on in the agenda. Actually, wait a minute, I missed a really important section here. So here we go. This is really important here. So subsection 6 here, subparagraph 6. This is where we were trying to add information that commenters were looking for that would be similar to Washington's rulemaking, where it gets more into the detail of what is required when they're in the event of an adverse benefit determination. Denies or limit coverage for gender-affirming treatment, the carrier must meet all the requirements, and we're listing the law and then the rules that would be applicable. There's a lot of information in that statute, but what we really want to highlight is ORS 743B 250 2H capital B, which I can also show you here in a moment. So that would include disclosure of the identity of the physical or behavioral health provider who reviewed the determination, which at minimum would include the provider's job title, specific role in the review process, a statement indicating whether the provider is an employee of the carrier or an independent contractor, and the provider's specialty, board certification status, and any other relevant qualifications that affirm their expertise in gender-affirming care. And then little b and little c, those are administrative rules that go into the detail around, let's see, 836.053.1030 is written information to enrollees. And the other rule ending in 1100 is the internal appeals process. So I have a few slides set up where I can provide that information for our discussion. If you haven't had a chance to look at those before this RAC, and I can do that in a moment to get down into the details of that.
Lisa, can I ask a quick question, which may play a role in terms of us continuing to review Section 6? From my understanding from the first RAC, this is when the DFR requests the information. That's when we need to disclose all of I through 3. Correct? I just want to make sure this is when the DFR requests it, because I think that's the clarification we were provided at the first RAC meeting.
Well, when there is an adverse benefit determination, that information can also be requested, I believe, by the enrollee. Yes, so I can pull up the slides to go down into these details if that would be helpful.
Okay.
Just a moment. Can you see my screen?
Almost. I can tell it. There it is.
It's trying. Okay.
There we go.
So first we'll start with, ORS 743B 250. And just to make a note that this statute was renumbered back in 2015 from 743 804. It was renumbered to 743B 250. So this is about required notices to applicants and enrollees, grievance, internal appeals, and external reviews. So this is to make clear and expand on what is already required for when there are issues, adverse benefit determinations, what the rights are and what the requirements are for carriers and what are the rights of enrollees. So I didn't list everything, but I just wanted to put the content in here that, section 1, A through N, gets into the detail about the information that insurers are required to provide all enrollees, and it includes, but it's not limited to, these topics here, including, information on how to obtain referrals for specialty care, emergency services, and out-of-network care. And on the next slide, it continues on, there's other information. And then I wanted to highlight that what is highlighted, what we've put actually by number and reference and rule, establish procedures for making coverage determinations and resolving grievances, which includes the opportunity for the enrollee or any authorized representative chosen by the enrollee to receive from the insurer upon request and free of charge reasonable access to and copies of all documents, records, and other information relevant to the adverse benefit determination. So I wanted to just highlight that information for you, since we are only just referencing the statute and not the in the case, not all the details, but I wanted to specifically highlight this one here that's in the rule. And then, as you can see, there's more content of what is required to be communicated, and then it ties into the rules that are referenced, written information that must be given to enrollees. And again, note that in the rule, the statute 743-804 was renumbered to 743B 250. So as you can see, there's a lot of detail, but we don't feel that we need to restate what's already in our administrative rules or other, statute in, other than referencing that in the House Bill 2002 Gender-Affirming Treatment Rule. But they're connected, so. And there's additional information here, what's required. And then I just wanted to highlight, make available that what this rule is about the internal appeals process. But there are timeframes, there are expectations, and a lot of those are clearly outlined in plan documents, the coverage documents.
Scott has his hand up.
Okay, I'll get right there in a moment here. Please go ahead, Scott.
Oh, hi. Thanks, Lisa. Scott White with Moda Health again. I just wanted to see, does that statute specifically, and I know you just had it up, just regarding the word identity in 6A, even though kind of at a minimum, you're not including identity, you're including credentials. And I just ask about this. I mean, we've had scenarios where and a physician's identity is not something that we wanted to provide, or tried to provide other things due to safety concerns of how we're being spoken to by individuals. And so I wanted to clarify, if an identity is not actually going to be required under the rule, would it be better to say something about information about the provider? Because that's what you're providing. My credentials aren't necessarily my identity, at least, and it may be semantics, but I just think that's important, because I've had members, fall back on things like that in other state statutes that, well, they look right past the minimum piece and go right to identity. And I've had providers have safety concerns about that in certain cases. So just wanted to bring that up and see if the ORS specifically used the word identity, or if we could do something about information about the provider. Again, not trying to not provide this information, but just want to be really clear about what we have to provide to avoid member complaints and things like that.
Yeah, I mean, that's a reasonable question. Thank you for bringing that up. What we have, in the statute, it says reasonable access to and copies of all documents, records, and other information relevant to the adverse benefit determination. So that's fairly broad. Not to discount the safety concern, but that's something I can take back and discuss with Brooke and Jesse and our other internal support on this rulemaking. So thank you for raising the question.
Okay. Thank you, Lisa.
We'll have to follow up. So there's a lot here and a lot to digest, but I would ask that you take the time that we can provide, leading up to the next RAC, and take a look at this and see if is it getting at what I think through written comments and verbal comments we've been getting, what we're trying to accomplish here. Transparency, making sure that there's information exchange so enrollees understand what's happening to their benefits. So that's that. I'm going to go ahead, and because we are at a little after 2 o'clock, not that RAC members and DFR staff can't raise their hand and make additional comments or ask questions, but I think we will go ahead and take the time, since we have it, to open the floor up for public comments for those that have been waiting, and then go from there. So please raise your hand if you would like to make a public comment. Yes, Paul, you may speak now.
Great. Can you hear me okay?
Yeah, we can.
Very good. Thank you. Yeah, so again, appreciate the work, the thoughtful work you've all been doing on this, and sort of allowing other stakeholders to listen and to make some comments. I think 2 key things. So the first, on the standard of care, the more I think about it, I would really discourage you from trying to define a standard of care at all. The way the statute is written, the standard of care is not just a laundry list of services that insurers need to cover. It's actually defining decision-making criteria for how CCO, or how insurer medical directors who are licensed physicians make medical decisions. And that in turn becomes sort of guidance on how all physicians in the state who want to get reimbursed by insurance need to make medical decisions. That's really not your area. You regulate insurance and banking and things. You don't really, regulating the practice of medicine it's just not your thing. You don't have the expertise. You don't have the authority to do it. The standard of care is something that just evolves organically over time. There is new research that comes out. Physicians are expected to stay current in their field. And it's really comes down to the physician judgment and the Board of Medicine that oversees that. Putting things into rule, particularly putting things into rule by an agency focused on finance, telling physicians how to make medical decisions is just not a good idea. There also, even in just the last couple of months while you've been working on this, there have been sort of new research and findings including some criticism a couple of weeks ago from the United Kingdom, specifically on the way the WPATH 8 standards were written that you should really be looking at. The second area is regarding detransitioners. So during the legislative process, Director Stolfi made some specific commitments to the Speaker about coverage for detransitioners, and stated that it was his opinion that this bill did require coverage of services for detransitioners. He gave a pretty detailed explanation of that and offered to put that into the rule if necessary. I have not seen anything yet in the rules or in this committee's discussion about services for detransitioners. From talking to people who might be affected by that, it does sound like a complex issue that's going to require some input, and this input you should really get from detransitioners and people who've been working on that issue. So I'd urge you to sort of follow through on Director Stolfi's commitment to address that. Thank you.
Thank you for your comments, Paul. Do we have anyone else that interested parties that want to make any public comment? All right, hearing none, I will offer the opportunity again for any last thoughts about the rule, anything you want to comment on, RAC members or staff, if our staff. And if not, I'll just start talking about our next steps. So I already previewed that a little bit for you, but the next steps would be, we're definitely going to have another RAC meeting. It's tentatively, we're looking at May 23rd. It's a Thursday, and it'll be in the afternoon again, like the 1 to 3 time period, or 1:30 to 3:30. And then I would ask that you please take into consideration everything we've discussed today, everything you've heard today, looking at the revised rule, and submit written, as detailed as you can, written comments by Thursday, May 9th. If you do need a little extra time or something comes up, don't hesitate to reach out to me and Brooke, and we will do our best to try to accommodate. Otherwise, we may be looking at giving you some time back, giving myself some time back to do some follow-up on the things I've heard today and the things that I promised that I would pull together for RAC members and interested parties to look at. So hearing silence, just thank you again for joining today. Appreciate your patience as we walk through all this material. It's really challenging. I appreciate your contributions so far, everything you've shared verbally and in writing. It's been really helpful to us in this process. So thank you so much. Have a good rest of your day. Bye-bye.
Thanks, Lisa. You too. Bye.
Thank you.
you.
Thank you.